Good evening, everybody. Is the mic on? Okay, good. Welcome to the ACO All-Payer Healthcare Forum. And I appreciate you all coming. And this is sponsored by Rights and Democracy. And we were lucky enough to have one of our healthcare work group members, Bob Block, be able to contact Todd Moore, who is the CEO of OneCare Vermont, as well as Norman Ward, who is the Chief Medical Officer. And I just want to give you a couple of logistics before we start into this. You'll notice that on your seat there's a sheet of paper and there's a pen, or if there isn't a pen on your chair, there's one next to you. So feel free to note any questions during the presentation that you may have, because there will be a question and answer period after this. And if you would rather have someone else ask your question, because otherwise the procedure would be to come up and stand at the mic and ask the question. If you would like someone else to answer your question, I'll go around and collect the sheets of paper from people, and someone else can read the question if you would prefer. And for logistical purposes, the restroom is located just past that exit sign on your left. And by way of introduction, you, I'm sure, know Rights and Democracy as an organization that is full-blown for single-payer universal care, both on a federal and a state level. And that's still true. But tonight, this isn't about that subject. This is about something that is already in place called an Accountable Care Organization. And we're going to learn exactly what that means. We also have some packets of handouts that Todd and Norm were nice enough to bring. I don't have enough for everyone, so afterwards I will hand them out, but I will keep one copy so that anyone that didn't get a packet, Rights and Democracy will go ahead and make copies and make sure that it gets to you. So without further ado, I would like to introduce Todd and Norm.
Thank you so much. Good introduction. We love getting invited places, so we're glad to be here. Especially by somebody like Bob Block. So glad to do this, and glad to meet some folks in Bennington. It was nice for us to make the trek down. Now, first rule of business is don't worry about the chief in either one of our title. We work for a living and really roll up our sleeves. Norm sees patients when he's not working on some of the stuff you're about to see here. So I think you set it up just right. Tonight we're going to talk about what is an ACO. We're going to talk then a little bit about what's Vermont's all-payer model, which is a major federal waiver we got in Vermont to do some great things and pave the way for improvement in healthcare. And I think you're right that we're not about the coverage and whether it ought to be public financing or not. I mean, we officially say we're sort of agnostic to that. How the money gets in the top of the funnel, we don't really care that much about. We worry about how we pay providers and incent them to deliver great care out in the communities of Vermont. So we do have a PowerPoint presentation that's not in the packet, but we will make it available via PDF from the organization. If anybody would like a copy of this after the meeting, we'll send it along tomorrow. I guess for the video, is it going to ruin things terribly if I move the slides and then point out things on the screen? Is that going to work? Okay, I think my voice probably should be loud enough that we'll hear it. Okay, so really, we're a part of reform. If you think of healthcare reform as two twin tracks, one is the whole coverage and financing piece. The other one is value-based care and value-based reform. And the Affordable Care Act had both those tracks in it. Act 48 in Vermont had both those tracks in it. And the reason why our track is in that level of reform is it's a combination of, one, unsustainable cost growth. And this curve right here actually is already adjusted for inflation. Okay, so this is as a percentage of gross domestic product, how much is healthcare costing us in the United States. And I love this slide, even though it only goes into early 2010s, because it starts back in 1960 prior to the Medicare Act, before we even had Medicare as an option for our seniors. And it's just grown and grown and grown. Even the flatter periods are followed by even sharper periods of cost growth historically. So what do we get for all that extra spending? Well, outcomes that are mixed, maybe not great. Other systems compared to the United States system, not as great. And the Institute for Healthcare Improvement, Triple Aim, which is in our circles very, very famous stuff, created by a doctor named Don Berwick, who was the administrator at CMS for a while under the Obama administration, that really said we got to do better on outcomes, cost, and satisfaction, because it's a complicated system that's hard to navigate. And there is a general belief that the fee-for-service system, where healthcare providers get paid for each encounter, is a big part of the problem. Okay, now what does it look like in Vermont? Well, it's pretty similar, and this is just something I pulled from the Green Mountain Care Board's annual expenditure report. The last one they released was published in May of 17 for the 2015 year. We're seeing a similar thing. As a matter of fact, here in Vermont, as a percentage of our gross state product, it's even higher than a percentage of the national product. And part of that is our population's pretty stagnant in Vermont, and not a lot of pure economic growth either. So as a small state, it's even more important to think about how we really can get on an affordability curve, no matter what the financing system and coverage system is. And that's the reason why this was a major part of Act 48 to get a handle on cost growth. Okay, so how does accountable care and ACOs figure into this? And I tell people I even get sick of using the term ACO. I've been living with it for 6 years, every day of my life, multiple times. But what it really means is accountable care is payment reform to providers based on accountability for a population of people's cost to deliver their care and the quality for them. And I know that sounds, well, God, isn't that what healthcare ought to be? This creates real programs for us to do that in a real way. And the real way is through an accountable care organization that a bunch of doctors and hospitals and other providers can get together to say, we're up for that challenge, and let's together organize ourselves around patients' needs and take that accountability to deliver what we call high value. That's the value-based piece of it, which is low cost and high quality. Okay, and who do we do it for? We do it for what's called an attributed patient population, and stay with me for a second. We get accountability for patients who have an established primary care relationship with a primary care doctor or physician in our network. They really, these ACO programs, if you know about the medical home model, the patient-centered medical home primary care model, it basically says that's table stakes for you to take accountability. If you don't own the primary care relationship, you're not going to be successful, because that's the quarterback and anchor to organizing around the needs of the patient. So I'm not going to read this to you, but a deeper definition is we get through our programs a per person spending target across large populations. Some people don't use a lot of services and just see their primary care doc maybe for a checkup or a sore throat. Other people, as you would expect, are in the hospital multiple times and might have an extreme amount of spending. But as you'll hear from Norm, this really helps us look at that experience across that whole continuum and have a game plan for every patient. Now, at the same time, these are all based on people's existing insurance plans and benefits and access. So this isn't like HMOs in the 1990s. We don't have any levers. We don't get to declare things medically unnecessary. That's up to the patient and their doctor to determine. We don't get to say what services should be covered or not your benefit. That's part of the benefit that you have. We can't say which providers from which you get your care. If your benefit allows you access to open networks, that's what you get to do. But we have access to your primary care doctor, right? Which is a treasured relationship and really can help us work to engage people in their own health and keep them healthy. Now, the way these targets are set to give us this population-based approach have been, for the last 5 years in Vermont, ones that once we get the target, if we beat it, we get to keep some of the savings as the providers. And it all goes back out to the doctors and the hospitals as incentives. But we're moving now this year under all-payer model into what's called risk contracts with those, meaning that target, if we exceed it, that we have to pay some of that money back that we would have received. That's a big deal, and in return for taking that, it's almost like we become an insurance company-like entity. It allows us to start doing some things. We can handle the money through the ACO to really start implementing payment reform and move from fee-for-service models to fixed revenue models that remove the volume-based incentive. It also allows us, if we do multiple contracts across multiple payers like we're doing now this year under all-payer model, is to align and blend money that came in the top of the funnel to OneCare from multiple payer sources and pay providers based on the panel that they serve in a blended way to sort of remove whose insurance card was it when they got here. Because we really want to do great care based on what the person's needs are, not how rich their insurance is or taking instructions from the payers. This allows us to own the rules a lot more as providers. And it allows us also to more substantially and directly reward high quality, right? We all talk about we want high quality and a high quality measured system, but try going out there and get somebody to say, do you want to pay more for high quality? They often will say, I'll take my chances and pay for the lowest cost. We, within what you'd otherwise pay, are putting some of our own money away to pay based on quality and move away from a purely volume-based system.
Excuse me, I don't know if I'm mystified by what you're saying.
Okay.
I don't know if anybody else has questions.
We will have a question.
But you're talking and talking and throwing out terms that I have no idea what you're talking about.
One thing I'm interested in, you mentioned people say doctor and I say insurance. So I don't quite understand what you do.
Yeah, how
I'd
do you
like
fit
to
into
explain
you?
that- I'd like to explain that at the beginning
Yeah.
because I'm totally missing.
So I have a really good
Yeah.
idea, because these are all great questions. And there's a piece of paper on
Yeah,
your,
if we don't know.
No, we
just
don't-
oh, you don't know what the
Talking about-
terms are.
No.
So maybe instead of an acronym,
Yep.
No, I'm totally lost as to what the
Who
organisation
you are,
does.
who are you? Who are you paid by?
oh, here, let me get you a, did you?
I've got
Oh, you
papers.
got it, okay.
Yeah,
It's just as another
Okay, so
level.
that's a question you can ask them when we have time for questions.
But
So-
it helps to set the scene so we understand what
So going back a couple of slides, an ACO is a voluntary organization of healthcare providers, doctors and hospitals and other providers, okay, that come together voluntarily to form a network called an accountable care organization.
So you're not profit.
So we're a nonprofit, not for-profit organization that we have contracts with doctors and hospitals, and then we contract with Medicare, Medicaid, and commercial payers to take accountability for cost and quality.
And this is a national trend.
There's 400 ACOs in the United States, and we're one of them here in Vermont. That's correct.
So you're another layer of organization.
We're new approach to the old layer of insurance companies. So we control costs by keeping people healthy and keeping them out of the hospital system instead of denying care.
And some of our questions may be answered as you go along, so other than about acronyms or, setting the tone of who they work for, it would probably be better for us if we held our questions to the end. So-
But I have no
Yeah, but I want
idea
people
what
to have
you're
I want people to have a handhold on what we're even
Oh,
talking
yeah,
about.
yeah.
So I don't mind that. Is that enough to keep going?
Well, maybe you could say what you mean by value care.
High cost or low cost, high quality.
And we'll have a definition of what that is, high quality at some point.
Yeah, we'll talk about how it works in our world, and that'll come up pretty quick. So if the idea is that the way we do well to control costs is to keep people healthy, there's a clinical transformation too that is from an encounter-based delivery system approach to a person-based delivery approach, which basically means instead of only talking about and delivering great care for who's right now in our waiting room and our exam room, we're going to have a game plan for every patient that keeps them healthy, and we might call the patient and say, you probably should come in for a visit so that we can keep you healthy. Okay, so the clinical part of the story, the rest of the thing is about healthcare delivery transformation. That's what this is about. Okay, the quality improvement is essential to this. And this is an example of our Medicare quality report card. There's 33 measures on here that we've tracked every year for 5 years. We have financial incentives to do well on this model. We measure this statewide for everybody in the network. And I don't know, Norm, if, as from a physician standpoint, how you want to characterize the measures. I know they can't see it here.
Yeah, so obviously this is the eye chart, which you can't read, but let me just say that the top 7 items here are about patient satisfaction. If you remember back to the 1990s when basically nobody was happy with HMOs, okay, the new ACO programs are all about patients being happy with the medical care that they get and that we measure the quality of the services that they receive. So the first 7 of those are all questions to patients about, are you happy with the communication from your doctor, nurses, your hospitalization? Have you been welcomed into a shared decision-making discussion about you were offered a surgery, but were you given the choices about what might be done instead? The other things are things like mammography rates, colonoscopy rates, all kind of bread and butter medical interventions, treatments and preventive things that the Medicare, for example, wants to be sure that we are going in the right direction and constantly improving our performance for patients.
So you have one of those for every provider?
We can do, yeah, we drill it down to individual providers. We do it regionally. We do it ACO-wide. ACO-wide measure is how we do well, but in Vermont, we have to get that incentive down to the local communities if we're actually going to move the dial.
Is this information available transparently, publicly?
Yeah, the Green Mountain Care Board, we report this every year across all our programs, and that will be available. The drill down to the individual providers is not. Okay, so think of this Medicare chart, 400 ACOs nationally working on these same measures, measuring it, and you know the targets are over here, so this really gets us nationally working on a set of measures, at least for Medicare, that everybody's trying to improve it, and the more everybody improves, the more the targets go up and the harder we have to do to deliver on the quality measures.
Can you give an example of what it is that you're measuring there? A specific thing, is it a procedure? Or
Sure, I said colonoscopy, for example. So everybody over 50 years of age, men and women, ought to have a screening colonoscopy to make sure that they don't get colon cancer. So we are measured against how many people that are on your panel have had a colonoscopy if they're over age 50. And if we have a low score, meaning only 10% of people had such a thing done, as opposed to 60% of people having it done, that's a better score. It's believed to be a higher quality medical outcome to deliver and have patients get these kinds of screening procedures, which have been shown to reduce, you know, morbidity and mortality.
Okay, so if the 60% is better, then what do you do with those facilities that get 60% as opposed to those who only get 10%? Is it
Right, so our network is all around the state. If we have one town like, you know, Burlington that has a low score and a town like Bennington that has a high score, and they're different, we compare notes and say, gee, Bennington, why are your citizens getting that screening test done more often? What language are you using to talk with them about whether to have it or not? And can we compare notes and maybe we can improve like you have done? So it's a bit of an exchange of tactics and information about how to get better.
It's part of Norm's role is to facilitate those dialogues and try to find out what are the barriers? Is it access? Is it referral patterns, et cetera?
And he just said you have these by region. Is that correct?
Yeah, we do it by healthcare service area and then drill down to practices where there's a big enough population at the practice level. And let me actually this actually is a good illustration. Another thing we do is a lot of informatics to try to assess the performance of our delivery system in OneCare. And so this roughly will show you what the value equation is. And so along the x-axis is cost per person. Along the y-axis is quality measurement on that report card. And so if you want to be at low cost and high quality, that's the high value quadrant. Every dot on this scatter plot, that's the 400 ACOs nationally. Okay? So Medicare has started a revolution where healthcare networks coming together across the country are competing against each other and incented to be in that upper left quadrant. Low cost, but high quality. OneCare right now is right there in the high value quadrant. We've improved quality scores in every program, including Medicare, every year for 5 years on these measurements. We've managed to stay relatively low compared to, this is the national average or the ACO average of spending per Medicare beneficiary, risk adjusted. Okay, so that's the game here. We together, for our attributed population that we're accountable for, the patients of our primary care docs, we want to score as high to the upper left as we can. Okay, now can I just do one quick thing because I want to address your issue. Okay, that's us on average, which is pretty good performance. But if you break it down by healthcare service area, same axes. Okay, each bubble is a different healthcare service area in Vermont. Look how much variability there is just in Vermont, right? And so we've been making rounds around the entire state showing this data and drilling down into what quality measures drive poor performance and what types of patients to try to get this to cluster. And it has clustered more over time. This is actually from a few years ago. It's more clustered now, but I just wanted to illustrate that even within tiny little Vermont with pretty good mean performance, we have, in some cases, 2x variability on some of the performance outcomes. We could really do better as a healthcare delivery system closing that and getting everybody where they ought to be up in the upper left-hand quadrant. And then the only third thing to say on this slide, though, is some of this is plain old thinking about medical care and access and that approach. But you got to realize that some of this is trying to engage people in their own health and get them to go in for the colonoscopy after it's referred by the primary care physician. Sometimes there's social and economic barriers to people engaging in their own health that now that we're accountable, we've really got to care about that, because between the primary care doc and people engaged in their own health, there could be a bigger worry about, am I going to lose my apartment next month? Or, do I even have food to feed my kids tomorrow? Do I need to get to the food bank, right? And so you notice here in Bennington, you're darker on these. These are from a, is it Commonwealth Fund or R.W. Johnson? Who does the county health rankings. They just released last week, I think, this year's version, where you can go on their website, publicly available website, and get tons of statistics for every county in the United States. And the darker colored ones are worse. And this is two things. Norm will talk a little bit more about this when he gets up here, but these are highly correlated. One is healthcare outcomes, the other is socioeconomic challenges. And look how close they are. So I'm going to pause there and get to your question.
Go ahead, I'll ask later.
What is 2x variability?
That means between the best performer and the worst performer, the best performer is twice as good.
So the metric is...
It could be any, I said that generically, so it could be even Norm's colonoscopy rates. Typically it's not 10% against 60%, it might be 30% against 60%.
It's just an odd way to describe distribution, that's all.
Yeah. Okay, this is a shift point to talking about all-payer model. What's Vermont doing to apply this? So I'm going to pause now to see, did I get us anywhere near understanding what we're trying to do, what an ACO is? I do want to pause right here, please.
So, what I understand is I still got, I've got my primary care doctor, I've got Medicare. So, and I go to my doctor. Are you overseeing my doctor and making sure that his standards improve, or are you something else? I'm trying to figure out where you fit into the system.
Yeah, I mean, we're trying, and this Norm will get to that. Why don't you answer that, Norm?
Your relationship with your physician is virtually unchanged from before these programs. You present complaints or symptoms to them, they take a history, they do a physical exam, they diagnose, they might do tests, they decide on a treatment plan. And these programs cause your doctor to be particularly interested in you following through. Because if you don't follow through, and just say you have diabetes, if we don't do a better job at treating diabetes more effectively, you might develop more complications. And to be crass about it, if you have poorly controlled diabetes and you become a dialysis patient because your kidneys fail, that's more expensive for the system, okay? And you don't want to be on dialysis, and we don't want you to be on dialysis, but we want your diabetes to be as well controlled as possible. In the fee-for-service world, you could go in and see your doctor on a monthly basis and basically be making no progress on controlling your diabetes. And there may be a lot of barriers to making progress, like you don't understand, you're more worried about food than medicine as far as your money, you don't have a car to go to the drugstore. There are lots of things that stand in the way of me thinking as the doc, oh, I wrote a prescription. These are the right pills. If they take this, they're going to be in great shape. But we have to start opening our eyes to the fact that there are reasons why people can't have better diabetes control, and we need to surround them with more services to help them understand and be able to follow through.
So there have to be more people employed to do that.
So
It's not just
one-
the doctor-patient, it's the doctor and the social worker and the nurse practitioner.
Coordination.
Yes. So there are helpers, there are more helpers built into this, more involvement of the community agencies, home health agencies, the area agency on aging. The nursing homes are important for our work, but there are many other agencies that help people. SASH, I don't know whether you know about the SASH program, but having that SASH worker in your typically, multi-family housing or multiple apartment housing, they are critically important to getting that health follow through for these folks so that we can get better medical outcomes.
Could you tell us what SASH stands for?
Support and services at home.
Okay.
It's an innovative program here in Vermont that was started basically with the Vermont Blueprint for Health. People that live usually in multi-unit apartment housing, they have services of basically a lay person who checks in on them.
Right.
And if they need a skilled nurse, then they can call the home health agency and they can work as a team.
Or if they need a ride to the doctor from their housing,
Right.
they can
Exactly.
arrange that.
So this is all to say that these connections and follow through and supports of people that are challenged with lots of other things going on in their life, and I'm going to get into this in a few minutes, but it represents a significant change and motivation for medical clinicians and hospitals to avoid high-cost things that represent failures of the system to treat disease very well. And chronic disease, poorly controlled, high blood pressure ending up with heart attacks and strokes, poor diabetes control ending up with dialysis and amputations and infections, and chronic lung disease from smoking, where people just can't breathe and they need home oxygen and their inability to lead a life is extremely limited. So the medical community has got to do something new and different to get better results.
Well, under a fee-for-service system, we have no incentive. If you go in the hospital 3 times, we get paid more money. Now, not that primary care docs don't care about that, but it's a little hard for them to think about closing the loop always and making sure that you got your prescription filled and got to the specialist, right?
And it also represents a shift of, if you avoid a $10,000 hospitalization by spending money on something different, like the social worker or the nurse care coordinator, to have the patient be more successful while their disease is simple rather than complicated and out of control, everybody wins. Yes,
I'm
ma'am.
sorry to interrupt, but I just can't hold back.
Yeah.
What you're saying makes sense, but if a person can't afford their co-pays or their deductibles, they're not going to be going to the doctor. So how is your program going to help that? How is it going to deal with those kinds of issues? dollars and cents.
And one word, HSA.
Yeah, and you know what? We can't just mandate that it's going to change, but you're right, that can be a barrier. And some people say, are you going to restrict access as a way to do well? I'm going to say I can't because I got all these satisfaction measures, plus it's not the right way to actually do it. We need to actually increase access for some things, like colonoscopies as the example, I guess, but other things as well. And, you know, when we reach that, one of the barriers is that they don't want to go get that procedure because they're out of pocket. Colonoscopies, at least under Affordable Care Act, are exempt from out of pocket. But, you know, we understand that. It is a barrier. We share that concern. I think the ACO can be a force for good in that. And as we negotiate contracts, try to figure out how we can reduce out of pocket, especially for things that do keep people well and keep them in a high quality of life. So, you know, force for good on that. We can't unilaterally solve that.
I would view these programs as an intermediate step. You would love for us to be able to just go to nothing out of pocket from the patients, which would be a nice thing to have. Unfortunately, you know, lots of people have thought about how to do that, and we're not there yet. This is an intermediate step. I think an improvement, because some of the things that we've been talking about, I think really do make really good sense.
Okay, let's shift to the all-payer model. And so this was signed in 2016 by then Governor Shumlin, Al Gobay, chair of the Green Mountain Care Board at the time, and the Center for Medicare and Medicaid Innovation. So it's a deal among those three that's based on ACOs as the primary construct, because Medicare, who pays half of Medicaid and all of Medicare freight, really likes ACOs because they like the population-based look, they like the financial accountability for sustaining those programs, they love the quality measurement, and they want a more coordinated system. It basically is, at its highest level, setting course for Vermont, all cost for all payers to grow at 3.5% for 5 years. Remember my graph with the upward curve that I said started with the Medicare Act? In that entire period since 1960, there hasn't been one state out of 50 that has grown at 3.5% or less, all in for a 5-year period. Never been done. It's been closer to 8-9% typically through other periods. So this is a pretty audacious goal to set, and I know a lot of people would love to have a 3.5% inflation rate every year. You know, some of this is because the population is aging, technology keeps getting higher. We do have a lot of unionized workforce in healthcare that you know, negotiate raises, et cetera. But 3.5%, you know, all in is what we're trying to shoot for a 5-year period starting this year. It does call for what is called scale population targets, and what that means is they want most of Vermonters to be members of an ACO, meaning have a relationship with a primary care doctor that's in an ACO by the end of the period. Okay, and part of that is to economies of scale, more quality measurement for more Vermonters, and make sure that we really complete the transformation that Norm is talking about. They did add, separate from our ACO program measures like that eye chart, statewide quality measures and goals that they are challenges as a state to improve during this 5-year period. One is primary care access. By 2022, they want 89% of Vermonters to have a regular primary care doctor. Suicide rate. They want us to quit growing in suicide rate and try to get closer to the national mean, an issue in Vermont. They have a lot of measures around mental health and substance abuse screening and treatment. Huge focus in all-payer model. And they want us to stop the growth of incidence of chronic disease. And the reason I emphasize incidence, this isn't just when you have it that we want to do the best practice and make sure you're on the right medication and seeing the right specialists for the chronic diseases Norm talked about. They want us to slow the growth of people getting it in the first place. And so one of the things that we really are focusing on is when people test with their blood pressure as what's called pre-hypertensive. So you're not diagnosed as hypertensive, but you're within those final 5 points. Or pre-diabetic, meaning your blood sugar was on the cusp. Those can both be reversed. with some interventions, some coaching, potentially some health resources in local communities, et cetera. So there's additional measures like that that even come in all-payer model. One of the things we got in the all-payer model was it preserved the Medicare Blueprint funds. So the Blueprint for Health is a long-standing program that Medicare contributed to through a demonstration that ended last year. And it pays primary care docs some of the money, so we would have gone backwards in primary care resources. It funds the entire SASH program statewide. And it contributes to all 14 Vermont communities' community health teams. So the community health teams were established through the Blueprint for Health in every community as a central funded resource to promote health and wellness in the community. Okay, for those of you who really know inside baseball, it qualifies as a CMS, the Medicare and Medicaid agency advanced alternative payment model, which brings other advantages and benefits to the healthcare delivery system of Vermont. Okay, this is year 1, 2018 of the 5-year all-payer model. The Green Mountain Care Board, in the agreement with the federal government, has more standing than any other state in the union's equivalent body. The legislature 2 years ago passed a law giving them regulatory authority over ACOs, of which right now OneCare is the only one in the state. And that includes us having to submit an annual budget and plan. And we've got to be certified to be an ACO under all-payer model. Okay, with a lot of requirements on do we have the capabilities, the approach, the policies and procedures that are required. Okay, the ACO contracts with doctors and hospitals to want to be part of this organization. We then also hold contracts with, separately, Medicare, with the Department of Vermont Health Access, who runs Medicaid, and with Blue Cross Blue Shield of Vermont for their qualified health plans, the Vermont Health Connect plans. And then we're piloting this year an employer-based health plan with the University of Vermont Medical Center, one of the providers in the network. So those are our 4 programs.
So if you have insurance from out of state because of employment there,
Yeah, and that's a great question. So you have to be in one of these 4 plans, or one of the qualified health plans, I guess, in Blue Cross Blue Shield. It's a range of plans. One of these 4 before we then see, do you have a primary care doctor that's in the OneCare network? Right, so we can add more contracts over time, but if somebody had an out-of-state health plan from Texas and just lived in Vermont as a branch office, they'll probably never attribute.
like in Massachusetts.
Well, it depends. I mean, there is some footprint for some Massachusetts insurers in Vermont. Okay, so we did our first ever budget under our new regulatory environment this past year to be ready for this year 1 of all-payer model. And some of the things of note in this is we ended up with north of 100,000 Vermonters across those plans in year 1, so it's a big step toward that goal of having most Vermonters in the program by the end of the 5 years. Hospital payment reform. Remember I said that once we move into the real advanced models, we now, for our providers who are part of the ACO, we now get to say how we want them to be paid. And hospital payment reform, so what we did was combine all the resources for hospital care from Medicare, Medicaid, and the qualified health plans, and we're paying them once monthly for over 100,000 Vermonters, and that covers all the care that any of those 100,000 people that come into your hospital get. You don't get paid fee-for-service anymore. So once monthly, it's a community capacity type model that you're open for business and you can't deny them access because we're watching for it and we're measuring it. Hospital payment reform of very high orders here.
It's a
Yes.
blanket payment?
It's a blanket once monthly payment that we distribute every month.
Who negotiates that?
So we take the money at the top of the funnel from the payers based on starting with what would they otherwise would have paid in a fee-for-service world. And we add all that up, what we expect to pay. Instead, we just get it in monthly lump sums to OneCare, and we immediately turn it around
Based
and
on
cut
prior
checks.
performance.
Well, the base, and that's a great, God, these are great questions. So in all-payer model, 2017 is what's called the base year. right? And so 2018 was easy to budget because the base year was just last year, right? And so we can easily translate what's a fair target and how do we do this. Now, as we move forward in this, we got to live under that 3.5% growth rate, right? And so one of the things the ACO proposes in its annual budgets will be, you know, do we give a little bit more than 3.5% to the people that did well on the quality report card and a little less for people who didn't do well, or other things like that that sort of represent, you know, over time how we want to reward value.
So this enables you to reduce the amount of bureaucracy in the hospitals that deal with billing and stuff like that. It's no longer needed.
Well, you know, in some ways yes, in some ways no. Now, they still have to send a claim for the encounter even though they're not going to get any money back for it, because those are so essential in tracking use, utilization. Governments use those to do almost epidemiology type things. If there's secondary payers that aren't part of this, they got to have the claimant to send to a secondary payer. So, you know, claims generation still exists, which is the first half of the administrative part. But the second part can get easier, which is you're not counting, did I get $112.16 like I expected on this claim? You know, it's just a once a month reconciliation.
Can I just clarify one point? When you say 3.5% growth, you're talking about per year, right? Not over the entire 5-year period.
That's each year for 5 years. And, you know, just to tell you how powerful that can be, that versus 4.5% for 5 years, even in a tiny state like Vermont, I mean, that's $600-700 million, just so you know.
How many dollars are budgeted for one care administrators?
So the one care budget is about $12 million for the infrastructure that is basically doing three things. One, which is negotiating these contracts and reporting on them and you know, the financial management. 1/3 on the informatics to actually get the quality measurements and performance analysis and tools out to the providers, and 1/3 clinical facilitators who basically work with and for Norm to be out there helping them design processes to improve care.
What does Vermont spend per year on healthcare expenses total? You're saying 12 million for this program. What do we spend on healthcare a year? 2016.
It's about $3 billion for medical care. Goes up higher if you include long-term supports and services like long-term nursing home care and other things. That gets you closer to $5 billion. Big numbers. Okay, primary care support and reform. Okay, so primary care has over the last 10 years been asked to do more with about the same amount of money, and a lot more, right? And even the medical home programs I talked about, which provided some supplemental funding on top of a fee-for-service system, have been pretty stagnant for a long time. And so we're actually taking, if you think of all of the spending for our 100,000 Vermonters, we're taking from the pie that is, you know, would have typically been expected to spend in hospitals for acute care, and we're taking a little sliver of that because there's so much money we spend on hospital services and giving that to primary care, what we call priming the pump. Because if this is going to be successful under 3.5%, at the end of the 5 years, we're going to be spending more money upstream in the community than in the hospitals relative to each other, right? And so this is part of spurring the system that we want to be there to be sustainably cost effective and live under a more affordable growth. Okay, community-based services support reform. Bring in the AAAs, area agencies on aging, our designated agencies for mental health and substance abuse, and our home health agencies truly into the fold with payment reform programs. So some of that slice I'm taking from the hospital spend is going to those three as well when they have a relationship with one of our 100,000 attributed members. Because their touches with those people in the community are really, really valuable. That's an opportunity to see, are they on their medication? Do they have a ride to their next doctor's appointment, et cetera, et cetera. So really bringing in a true, what we call the continuum of care in its broadest definition of everybody who touches that person. Let's build a team and a plan for how we're going to support them. Continuity of the Medicare Blueprint funds. So effectively, we're picking up the tab to replace those Medicare funds and wouldn't be able to do it without the all-payer model. And then significant movement toward true population health management, so taking the next step on the things that Norm is going to talk about. So Norm, do you want to take over from here?
So this is the map of Vermont, as you can figure out, and there's some green dots on there, and the list of the communities that are in OneCare in 2018 are Bennington, which is working just with some Medicaid patients this year. We hope that Bennington Hospital and your local doctors will start participating with Medicare and the Blue Cross plans next year. But Central Vermont and Berlin and Brattleboro, Burlington, Middlebury, St. Albans, Springfield, and Newport and Windsor. So you might say, well, which communities aren't participating this year? We hope that they will take part next year. So Rutland, Randolph, St. Johnsbury, Townsend with Grace Cottage Hospital, and who did I forget? Rutland, Townsend, Randolph, St. J, and Copley. Sorry, I forgot Copley. So 9 of the 14 hospitals in Vermont have seen some wisdom in deciding to do these types of programs. So this is the approximately 122,000 Vermonters that are in the OneCare network, and the red box are the people that are attributed, connected to Bennington primary care doctors, or nurse practitioners, or physician assistants, because we know that some of you may get the majority of your primary care from non-doctors, nurse practitioners, PAs, naturopaths, whatever. So you've got about 5,500 Medicaid patients from your community in the OneCare program. There are some little bits of noise here in terms of these numbers for Blue Cross and Medicare, but you can see that the distribution of the patients in the different communities is pretty well represented in each community.
Norm, could
Yes.
you explain something?
Yeah.
But supposedly we're only taking Medicaid.
Yeah.
But yet you have Medicare and.
That's the noise.
That's the
Primary Care Health Partners, which is a statewide
That's right,
organization
that's right.
of multiple primary care practices, has been a long-term member of OneCare, and they have a Bennington area practice. I can't recall exactly what it is. There's a
Mount Anthony.
Mount Anthony practice.
Okay.
And so rather than exclude them altogether, because they're either all in or all out, we took them.
I'm glad we had the explanation of where the noise came from, but they're in as well. So what does this all mean? Maybe we should have started with this slide. But how does the Vermont all-payer model and OneCare help make Vermont's healthcare delivery system better? We're already blessed with pretty darn good healthcare in Vermont. We certainly don't want to do anything to mess it up, but as Todd said, Vermont is not immune to those costs going up. And it's killing the country in the sense that as the medical industry starts to consume more and more of our total dollars, things like streets and education and transportation, they all suffer, okay? So having a responsible medical system that's getting the most quality for the lowest cost is really important.
Excuse me.
Yes, ma'am.
But when you say you're going to increase at 3.5,
Yes.
you're going to start with the enormous amount of money that we have to pay today. You're not going to try to reduce, you're going up. So where are we going to be saving?
Okay, so
Assuming that you're not going to go any more than 3.5, but what about the enormous amount of money that we pay already? What are you going to do for that?
So the way I think about it is that if we're able to stay at 3.5% instead of the historical 6 or 8%, we're going to let the rest of our income and the economy sort of get into better alignment with the medical spending. So that over time, it's going to be really important for us to to get closer to regular inflation for medical care, similar to the rest of the economy. We can't snap our fingers and make all of the expensiveness of healthcare go away right away. So it's going to take some time, and I wish we had a magic solution, but anyway, that's my response.
No, I know, but something has to be done to decrease the enormous amount of money that we are paying now. So I am not impressed with getting it to 3.5% increase. I know that's all you can do, but what really would be impressive would be for 10 years, you would be decreasing it 3.5% every year. That would really be impressive.
That would be really impressive. And I'm with you 100%.
We'd be up for the challenge of trying, but this is one of those examples of when's the best time to plant a tree 25 years ago, when's the second best time right now.
Yeah.
Right. That's sort of that example of let's try to keep the hole from getting any deeper as at least a first step. But I totally hear what you're saying.
Yes, ma'am.
So I have a question, keeping cost to 3.5%, what is the, like insurance, I have Blue Cross Blue Shield, what's their commitment to not raising my premium more than 3.5% next year?
So the Green Mountain Care Board is watching the whole experiment.
Yeah.
Okay, they're watching how the increases go in Medicare, how they go in Medicaid, and what Blue Cross is doing as well. So they have regulatory authority to say yes they can or no they can't raise rates. So
there's no guarantee in terms of, there is some.
There is some oversight, and I think that the Green Mountain Care Board has that as one of their charges, one of their tasks, to watch and try to make this experiment work.
Is
So
there a
what?
commitment for the insurances to stay in the state?
I'm sorry?
Is there a commitment from Blue Cross to continue to offer in the state for the 5 years?
Well, Blue Cross Blue Shield of Vermont only does business in Vermont. I think the chances of Blue Cross Blue Shield going anywhere else is highly unlikely. But there's no guarantee in life. But I think it's highly unlikely that would happen. So, better coordination of care. We all know that medical systems are extremely complicated. You get a disease, you're very vulnerable, you go to your doctor, and the treatment plan is decided on or suggested, and then suddenly things get all discombobulated because nobody's talking to people, things are forgotten or there's confusion. So we want to improve the communication between all of the people, the doctors, the hospitals, and the community agencies that are touching patients. Patients with complex illness know this better than anybody because they constantly feel like they're telling their story over and over again to people who they think should know their story. So some of the tools we have put in place are some communication tools so that people don't have to tell their story over and over again. Facilitating new ways to care for patients other than just office visits. In the fee-for-service world, to be crass, if your doctor is making phone calls to you, they're doing it for free. Okay? They're not getting paid to call you on the phone. They're not getting paid to send you an email. They're getting paid only when you come in for an office visit, which is sometimes extremely inconvenient for people that are on the job, people that are homebound, people that don't have a ride. So this type of payment system allows for us to start to look at, for example, doing telemedicine or Skype visits with people in their homes or being in the nursing home, having the doctor lay eyes on people without having to drive 30 minutes each way or having the patient having to drive 30 minutes each way. There are some very interesting waivers, new benefits in Medicare that come only with these types of programs. One of those is that if you need to go to a nursing home after a hospitalization, the current rules are you must spend 3 midnights in the hospital. You have to have been sick enough to have 3 days in the hospital. If you're discharged from the hospital on day 1 or day 2, and you still need to go to the nursing home, that will not allow Medicare to pay for the nursing home. In this new program, we are working towards if you are well enough if you got well enough after one night in the hospital that you can go to the nursing home and that will be paid for from your Medicare as if you had spent the 3 nights that would be unnecessary. So this is trying to streamline and get people what they need quicker and easier. Using data to help outreach to patients in need. What do I mean by data? Whenever your doctor or hospital bills you, they have sent, a request for payment to the insurance company. And when any given clinician, doctor, is taking care of a patient, we sometimes don't understand all of the conditions that are happening. By having this information, we can help reach out to people to help them have better coordinated care. I've already mentioned the better treatment of chronic diseases like diabetes, high blood pressure, and lung disease. We are working on some educational programs that emphasize the patient perspective on what they need. So the handout about the dementia series on Monday night, there's some flyers here. For example, we're having a WebEx. You can sign in and learn about how new programs about the key in Alzheimer's disease. The drugs have been terribly unhelpful, but for people to live in a better way with Alzheimer's, educating the caregivers to understand how to approach their loved one who is demented is extremely important. So we're trying to advertise and educate not only doctors and nurses, but everybody in the community about that. We're working with the Alzheimer's Association, so educational programs, and then shared decision making. I think I alluded to this before. When your clinician says, I think you need this operation, let's just say prostate, for example. I'm up at night, I'm a man, I've got a big prostate, I'm up 3 times to pee every night, And so I get recommended that you ought to have your prostate reamed out, okay? Well, the fact is, if I don't have prostate cancer, and I'm willing to put up with going to the bathroom 3 times a night, I'm not really critically needing a surgical procedure. So it's educating people about what their options are better, more thoroughly. Humanity is made up of people that are healthy. They might have one disease like high blood pressure. They might have several chronic diseases like they have high blood pressure and diabetes and heart failure. And then there are people over here that are really, really sick. And they are extremely complicated and extremely expensive. So we have to have a plan to try to deal with caring for people in each of these quadrants better. So up here, it's let's be sure they get their flu shot and their pneumonia shot and the children in for well child visits. Up here, it's like Todd was mentioning, gee, you've got pre-diabetes, you're overweight and you don't exercise. Can't we do something to prevent you from actually becoming a diabetic? Down here is, okay, you've got diabetes, but let's try to control your diabetes really well. And over here it is that the whole system needs to communicate better because these folks are really, really challenged.
Excuse me.
Yes, ma'am.
Why you're not counting in trying to help people with chronic diseases like diabetes? And I know it sounds awful to say that, but I am a diabetic,
Yes.
and it took me 6 years to find someone that really understands, and I was going to supposedly good doctor.
Yes.
It took me 6 years to finally find someone that can control my diabetes.
Yes.
But in order to control the diabetes, I have to call them every week and tell them my values. I have to take my blood values 4 times a day and so
Yes.
forth. Now, what happens with your quality of patients if it is not their fault, if it is the fault of the physicians that are, physicians, like anything else in life, is an average. There are some very good physicians, most of them are just mediocre, average, and then you have the bad ones.
Mhm.
So what about if you know,
Yeah.
with the really good physicians, your quality it's not going to be good. Do people realize that the quality is not good? How do you measure quality?
Right. So these programs and comparing the outcomes of hospitals and individual doctors is in its infancy. And your expectation is not unreasonable, that we ought to be able to somehow have some sort of a score to guide our decision making.
I agree, and I think this is the perfect example of what do we do. We find out, why did it take 6 years? And if it worked for you, there's probably 100 other Vermonters that have similar attributes, and shouldn't we, on day one, implement that best practice? So that's part of what we're trying to do, having access to the statewide network and information to come up with what are some best practices that seem to work, to have a game plan for every patient that's going to work for them, offer that as a toolkit, knowledge to the local communities and those physicians to implement. We don't deliver care, we facilitate communities and providers in delivering care. They want you to have controlled diabetes. If there's a best practice and we can get there a lot sooner, that was a failure of the system, in my opinion. That's what we're trying to avoid.
Oh, sure.
So this just illustrates what I was saying about those folks in the very sick left lower part of the pie. The top 5% of people are the 5% sickest people are responsible for about half of the medical spending. So part of our programs are we're paying attention to everybody, but when it comes to making investments in social workers, nurse care coordinators, other community supports, if we don't succeed here, you could say your biggest bang for the buck is here because they represent a huge amount of spending. So every time somebody gets discharged from the hospital and they don't understand their pills and the equipment isn't delivered and they end up being readmitted to the hospital got paid $10,000 the first time and they're going to get paid $10,000 the second time. Well, in these programs, that second admission is not acceptable. It's not acceptable now. It shouldn't be acceptable now if it's an avoidable oops, okay? But we need to get more efficient. We cannot accept that kind of mistake. We can't get readmissions down to zero. People go home from the hospital, and some of them, despite the fact that they were well enough to go home, they just get sick again because their disease is hard to control. So that upper left-hand part, the healthy people, so one of the programs is called Rise Vermont. Up in St. Albans, they've had a community program that involves the schools, the employers, town government, the hospital, doctors, and the community agencies. It's really a well-organized system of let's combat childhood obesity was the #1 first goal for the program. Let's get our community interested in having physical activity, walking paths, bike paths, etc. Let's advertise these things. Let's have great attendance. Let's have a healthier community, and let's eat better by having better access to healthier food. So just an example of the kinds of programs, and OneCare is helping to support the Rise Vermont, which is spreading around the state to eventually all of our communities. Todd already mentioned this. All I gotta say again is that, remember, the areas in dark on the map of Vermont, which unfortunately Bennington is in, are poorer medical outcomes. And when you go to understand why that might be true, or at least contributors, there are economic issues, there are poverty issues, and other social determinants of health that make it harder to get a more well population. We have to start screening for people who have food insecurity, who have transportation needs. And my next slide, I think, is, well, it isn't here. So it's about care coordination. And one of the the newly understood things is that people's lives are complicated for lots of different reasons. And as you know, if you go to talk with somebody and they insist that they're right and they know better than you about where you ought to start with sort of trying to make progress on things, you know that that doesn't seem exactly right. So there's a tool called the Camden cards, which allow people to basically sort the cards into piles, which say transportation, employment, marital problems, health problems, you name it. About 20 different categories of how your life can be not so good. And these are important and I want to work on these right away. These are not so important and I don't maybe ever want to work on these, but these are my priorities. So it's that kind of educating nurses and doctors about new approaches to getting behavioral change and progress on doing medical care better.
Will there be more drug treatment centers? Because that is a problem, and we've talked about
Right.
all kinds of illnesses.
Right.
But people have been asking for that.
Yeah.
Would that be something, because that is something that is needed in
Right.
our state?
Right. So right now, the hub and spoke opiate treatment programs are paid for by Medicaid. So people with Medicaid have pretty good access to those services. Blue Cross pays for some of it. Medicare really doesn't pay for those kinds of services. So there are some ongoing discussions with Medicare about how that might happen. And the fact is that the ACO, because we exist and because we have these kinds of relationships that we have, may actually allow the state of Vermont to have Medicare provide that as a benefit where it might not be provided in another state.
But where you're talking about people with transportation,
Yep.
I mean, miles they would have to go in our state to get to part of their hub.
Sure. So, obviously Medicaid has help with Medicaid taxi services for people with Medicaid. I don't know exactly what the Medicare benefits are going to look like, whether it's going to include a transportation component or not. We have a relatively,
Those are programs where they have to go every single day
well,
to get their medicine.
well, that's methadone. Okay, that's methadone programs, but Suboxone can be weekly or every 2 weeks.
And every day.
We have a Suboxone clinic here.
Right. So depending on how stable the person is, once they get really stable, they can go to weekly or even every couple of weeks, which will save lots of aggravation. So all of medicine is huge and complicated. So our network has picked some categories of stuff we want to work on. So I only say this just to try to reassure you that we're trying to cover lots of bases. So we've been talking a lot about those high-risk patients. We want to improve the coordination of care. Episodes of care. So what we find is, and you may be surprised, that in some communities, if you have your hip or knee replaced, which is the most common operation in Medicare, in one community, they were sending 2 out of 3 people to the nursing home. And in some communities, they were sending almost nobody to the nursing home. So what's the right answer? Does every hip or knee person ought to go to the nursing home or not? The right answer is probably somewhere in between. They weren't exactly comparable communities, but just by pointing this out, the decision makers, the orthopedic surgeons, for example, they said, wow, we really are different. Maybe we ought to reconsider whether all of these nursing home discharges are absolutely necessary. And we saw a considerable decline in nursing home. People can either go home with the visiting nurse to come and do their therapy at home. They might spend less time in the nursing home, or they might go to the nursing home, or they might go to an acute rehab facility. So just to give you an example of pointing out differences, then let's discuss why the differences, whether it's real for a good reason or whether it's just habit or, you know, the way we do things. Mental health, Todd already mentioned the fact that, just to tell you that people with mental health diagnoses in our Medicaid program, if we separate the 30,000 or so Medicaid patients into two groups, those with anything like a mental health diagnosis, depression, anxiety, schizophrenia, manic depressive illness, versus not, what would you guess the medical spending is as a multiple for the people that have that anything like a mental health diagnosis? Is it one? Is it double, triple, 4 times?
4 times.
It's 3 times. Okay?
That's
So
assuming they can actually get that care.
that's true. But so the question is, do people with mental health problems, are they seeking care because they're anxious and going to the emergency room every day? Some people do. Or are they so afraid of seeking care that they actually get so sick that when they finally present for care, they're extremely expensive? So I've heard theories both directions. What's the truth? I don't know. All I know is that if we continue to not invest in better control of mental health problems, we're going to continue to be more expensive medical system because of both reasons of the medical spending is higher. Chronic disease, we've sort of beaten that to death, except for the fact that if you have heart failure and you call your doctor's office on a Monday morning short of breath, and if the doctor's office is not in tune with the fact that you have heart failure and you're short of breath, and you probably need a little bit more fluid pill dose increased to get you to pee out some of the extra fluid. Because if you don't do that, on Tuesday you might be in the emergency room, and Tuesday night you may be in the hospital. So why don't we get with the program and understand that there are ambulatory sensitive conditions, which means if you're still an outpatient, you're still in your own house, you make that phone call, you have a symptom, let's treat the symptom promptly so that you don't end up needing to be hospitalized. And that's true for heart failure, it's true for emphysema and chronic bronchitis as well. When you have emphysema and you get a cold, that can be a real problem because your emphysema and chronic bronchitis is going to act up. Maybe you need to be seen that day, maybe your oxygen level needs to go up, maybe you need to be on antibiotics or steroids as pills instead of waiting to get really bad and having to have an expensive hospitalization. Prevention and wellness, let's get people in, especially our adolescents who are currently very poor at getting in to see primary care for, let's head off their risky behaviors, their risk for substance abuse, their risk for sexually transmitted diseases and the like, and then those social determinants that I was mentioning before. I think that's the end of our slide deck. So I think we're open for questions.
That's great. So we will take questions, but for anybody who came in after I said these are the packets that our friends were just referring to, and a lot of the slides are in these. We may not have enough for everyone, but I'm going to keep one packet and make copies. So if you don't get one before you leave tonight and you want one, please let us know. They are also going to take their PowerPoint presentation and email it down to us at Rights and Democracy, and we are happy to email it to anybody who wants it.
And there's some other one-pagers here about how care coordination has been successful, that doing some of this new stuff is having some success.
Great.
So that's care
Thank
coordination, and this is about better control of high blood pressure.
Oh, great.
Paying
Great,
dividends.
so I'll also keep these here. So At this point, I would love to open the floor for questions.
Like we had a first
and-
hand over here. I saw the person who had his first hand
Okay,
up. so
great, and here-
I'm stickler about that.
That's fine, that's fine.
Go
ahead.
So I really appreciate everything I'm hearing that you're trying to do, and I think there's a lot of value to it.
Could you stand up, please, so we can hear you?
Sorry.
In fact, if you can go to the mic
Okay,
if you'd
I'll-
like.
I'll speak louder.
Okay.
I really appreciate everything I'm hearing that you're trying to do. I think there is marginal improvement that can be made there. At the same time, it does appear to be another layer of bureaucracy and another layer of coordination and another layer of cost. And ultimately, if we're going to drive costs out of the system, we have to get rid of those extra layers of bureaucracy. So I hear all the good intentions. If eventually we're going to try to get to something like single payer, in my mind, are you going to be helping us get there, or are you going to be another layer of bureaucracy fighting that?
So let's talk about that for a second. Department of Vermont Health Access has about 280 employees. Blue Cross, 350. Medicare, tens of thousands. We're 45 or 50 people that can do this because we're facilitating the local communities. We will be the lowest cost option for a layer that must exist, right? Somebody's got to set up the central infrastructure to take the source of funding, whether it's taxes or premiums, and get it out to the providers who are out delivering services and need to pay doctors and nurses, okay? All three of the layers people that I mentioned, DIVA, Blue Cross, Medicare, hire people that try to, via telephone, sometimes thousands of miles away, do some of this stuff, call people to ask them, how's your diabetes working out? We're trying to build that into what happens in the day-to-day delivery of care with your doctor that you actually see.
So again, I appreciate what you're doing. I'm not taking any.
But what I'm
trying
saying,
to get to where the end
what I'm saying, it isn't an extra layer. It's
Yeah.
the cheapest way to do a layer that exists now at 10 times the cost.
Okay.
Because they're trying to fill the gaps in a system that in fee-for-service is fine being fragmented. Right? And that's the reason why payers spend so much money on, well, let's just determine something not medically necessary, or we'll have a doctor at the insurance company decide if you really need that. No, actually, I don't think you need the prostate procedure done from the payer side, instead of shared decision-making with the doctor. Like, there's literally hundreds of employees, even in Vermont, that don't need to do it anymore if we can put the incentives, tools, and systems and motivation out there in the day-to-day delivery of care in the local communities.
Thank you. I think Eric had a question.
I agree too. It seems counterintuitive to add to the bureaucracy in order to drive the costs up, but I see the value of this, and I see it as really greasing the skids for a single payer. Because a lot of the arguments against single payer was, well, how do you manage the cost? How do you manage the quality? If the government's involved, it's going to expand. But you're controlling those costs and keeping it at 3.5%, which is amazing to do. And so it does make sense. I didn't understand what an ACO was coming in here, but definitely see the value. I get two questions. Just, is 3.5% what the other ACOs are doing nationally, or is it set by each ACO? And then how do you get the hospitals to want to join? Because it seems like you're taking money from them if they're for-profit and they are seeing lower admissions.
No hospitals in Vermont are for-profit, they're all non-profit. That's one thing. And the second thing is the payers set the targets in most of these ACO programs in terms of what they will allow the growth rate to be. So for all the other ACOs in America, it's Medicare that sets their target. We're the one out of the 400 that the Green Mountain Care Board sets our target. I mean, that's actually the real nuclear core to the all-payer waiver, is that the Green Mountain Care Board gets to set our targets. And this past budget cycle, our whole budget submission had to include what we're budgeting as what we think is the right target to live within this 3.5% growth rate. And they review it, and you would have a chance during that cycle to read our budget submission, provide public comment, go and hear our presentation, advise the Green Mountain Care Board, and it would be up to you to say, I think Green Mountain Care Board turn the dial to 2% this year instead of 3.5%. I think they can do it. That would be your prerogative as citizens. And that's the transparency that we have of the ACO model in Vermont that doesn't exist anyplace else. And trying to do, the other thing that's unique about us is trying to do this aligned multi-payer thing. There are ACOs that have contracts with different types of payers. We're the only one that's trying to blend those together in a common model. And I mentioned the hospital payment reform. We're also piloting in 7 different practice sites, primary care practice sites in Vermont, a blended, what's called capitated model for primary care, where we'll pay you once monthly for your attributed members of your panel in a blended way. Well, here are the names. Some of them are Medicare, some of them are Medicaid, some of them are commercial, with a blended fair rate with some extra resources because we want to invest in primary care, getting them ready potentially for a world where there could be public financing, and that's the way they would see the world. They would just get a rate per person that is on their panel. So there are elements of this that start to blend away sort of the payer layer and the payer based model that I think providers are getting pretty excited about.
We haven't mentioned at all pharmaceuticals tonight, okay? So it's a big piece of the pie, and we are not yet responsible for the pharmaceutical part of things. We are when you get a drug in the hospital, but that whole system, we're putting our toe a little bit in that water, but it's a little scary, wouldn't you say? That it's going to take some time before we have the confidence that we can lead clinicians to understand that drugs are really expensive. Maybe there is a lower cost alternative. I mean, we all would love for the strength of the pharma lobby in Washington to not be as strong as it is, so that the drug costs that they charge us retail would be less. So I just wanted to be sure to mention that we are not in the
one big piece
taking risk on drugs.
And that's all built in your premiums, and that is part of the affordability. So
I know Bob had his hand up, and I know a couple other people. I see you in the back. I think.
No.
Go ahead.
Actually, I was just going to ask you about pharma.
You read Dr. Block's mind. Thanks.
I won't forget.
So did I answer it?
Well, the Senate has been talking about creating some type of buying where we would buy through Canada. Would you folks be behind that?
Would you have anything to do with that?
Well, probably not much to do with it, but would we be opposed to it? No. I mean, if we're about affordability. I don't know if there was something we could do and we were asked to do it. I'm sure the answer would be yes, but I'm not sure what it would be.
Could you repeat the question?
Question is, if the state of Vermont found a way to actually acquire drug stock in Vermont from Canada as a way to make it more affordable, can you help with that?
But how to negotiate costs like the VA does
Yeah.
in Vermont. That's what they're proposing.
Like I said, the Medicare drug costs, you've got to talk to Medicare in the current world. The drug costs in Medicaid, you've got to talk to Vermont Medicaid. The drug costs for the Blue Cross plan, you've got to talk with the Blue Cross drug supplier. So we're not in that area yet. We're starting with doctors and hospitals, basically. That's a start.
Was that your question in the back, or was there another one?
Who, me?
Yeah. Or yes, didn't you have your hand up?
Yeah, I did.
Okay.
No, my cost has to do with the fact that, the data does show that around the country, ACOs are not necessarily keeping healthcare costs down. There's a real failure. So what is Vermont going to be doing that's different to help keep costs down? Do you have a plan with your...
Great question. We're building it in that growth rate ahead of time. So you're right in the what was called the upside-only shared savings, where there was no paying for overspending, very weak incentive, really hasn't worked financially. Quality improvement has been big time. So basically, that's that 3.5% model. Is we're putting our money where our mouth is and saying we will deliver affordability. 3.5% was the number that the administration, DEVA, the Department of Mental Health Access, and the federal government said would represent value because it would naturally grow at higher than 3.5%. So we're basically pre-granting the savings
Really working
ahead of
to
time.
keep that percentage down. If they weren't able to do it in other areas, though, is there something that you're
So
seeing?
honestly,
Yeah.
I honestly describe our mission as trying to live at 3.5% inflation without ruining the delivery system and having you guys have to wait months for access to care and not having a primary care physician. And still having a local hospital that provides the services you need. That's what we're trying to do, right? The pinch point is if naturally you grow at 4.5% and we're locking in and taking accountability at 3.5%, we got to get out ahead of some of this stuff, and that's why we have more attention to the providers to want to do more things right and have tools and best practices than we had over the last 5 years. It's really made a big difference now that we've made that commitment.
And I think what you're commenting on is that there were like 350 Medicare shared savings program, and that's what we were for the first 5 years until this year. When you start to take financial risk, it opens up, and the fixed capitated payments to hospitals especially that Todd was talking about, whole new options start to open up about some of the stuff I was talking about of let's do the phone call, even if I don't get to bill that as a 99213 office visit, because it's part of excellent care, convenient for the patient. I've already been prepaid for my services to take care of this group of people.
Okay, I think there's a question here and over there and there and there. And go ahead.
This actually ties in with your risk sharing and incentives. It's very easy to describe how the system is designed to work, and there's usually a gap between the way it's designed to work and the way it actually works. When you take that into account and you look at the risk sharing, it seems to me that there's a real potential there for providers to kind of keep track of the type of patients that they're getting. Your own slides show that some patients are pretty much going to eat up health care that you wouldn't believe. So isn't there an incentive for the provider to either avoid high-risk, high-cost patients altogether, or if they do accept them, to cut corners on the care to make sure that they stay below that cost threshold? And related to that, but somewhat different, you're obviously going to be trying to monitor the quality of care pretty closely. As you're doing that, what do you have built in terms of taking account of these high-risk patients? If one practitioner has 300 patients and 10 of them are high risk, that's going to be a very different situation than someone who has the same number of patients but 60 are high risk. So both of those questions really kind of
Good questions.
So I'm part of the University of Vermont Medical Group. I'm on the faculty of the medical school. And our group is talking about the fact that the panel size for a family doctor needs to be a mixture of numbers and risk, how sick the panel is. So that if you've got a panel of 500 really sick people compared to your partner who has a panel of 1,000 people who are quadrant 1, quadrant 2, my salary from the organization for me and my partner, maybe with the sicker panel of patients, might be the same because we're kind of equaling out, balancing out the amount of work effort that it takes to take care of two panels that look pretty different. So I think that's my attempt to say that the idea that people will ignore the sickest people, the fact is there is no way for us to avoid those folks because they will have contact with the medical system and they will be attributed, and it becomes our job to do the best possible job we can with them.
Well, when you say they will be attributed, I assume you mean that if they don't get care, they're going to end up in the hospital.
So
What about
So a big part of our world is risk adjustment. So all these economic models are risk adjusted. Now we're really good at, based on the medical diagnoses, adjusting for what diseases they have and how progressed are those diseases. We're not very good at saying two people who look the same from a disease state, but one of them's homeless and the other has a good job, that one is clearly higher risk and higher complexity to try to get them engaged in the healthcare system.
I don't want to be a pain.
So if you're if you're Dr. A and Norm's Dr. B, and your risk score is 1.5 and his is 1, you're going to get 1.5 more money for your practice.
That's the last question I asked. I'm still worried about the avoiding high-risk patients.
Yeah, you're going to get paid more money with the high-risk patients with models that are meant to be fairly represent the extra complexity for you.
Okay, so do I understand you to be saying that you don't think there is an incentive for like a primary care doctor to avoid high-risk patients?
Actually, I'm more worried about the opposite. Because we're paying them more for higher risk patients. And the higher risk patients have the better opportunity to avoid hospitalization. Somebody who you think's probably going to be in the hospital the next year, if you can avoid it, that saves a lot of money. Somebody who's well, that you're going to get paid less for, you're probably not going to have that ability to, avoid an admission. So really, we have, I'll tell you one model we have for quadrants 3 and 4, so our highest risk patients, we're paying for every attributed life 50% more for those patients. So if you had a panel that was all of them, you get paid 50% more. It's an additional $15 per member per month on top of the all quadrant-based payment.
I think there was a question over here.
I just can't help but I want to go back to this whole pharmaceutical issue. That is a big percentage of what is causing the rising cost of overall health care. Why can't you be thinking and doing something about negotiating with drug companies? The VA is the only place in this country that does that. Why can't we're talking about people power. You're talking about wanting to get more and more Vermonters involved in your program. That's getting more people with more ability to control prices.
I wish I could say that would work, but the people negotiating with the pharmaceutical companies for your pharmaceuticals here are CVS.
Who is CVS?
Right, and the state of Vermont, CVS pharmacy. So I don't know, you have Rite Aid in town?
Well, we have CVS.
Okay, CVS, right?
Walgreens.
Right. The University of Vermont Health Network is part of a group that has all 125 academic medical centers in the country, each multi-billion-dollar organizations. They get together to negotiate rates for pharmaceuticals, right? OneCare Vermont, we could try to get a better deal, but we're probably not going to get a better deal than they can. And I understand that the deal they're getting isn't affordable. I totally get that.
It's out of control.
Bigger problem than I can solve.
If you're trying to work to keep prices down, that would be one area that would be really great.
So I'm going to be in line between a guy who's buying $1 trillion of pharmaceuticals from CVS. They're not going to listen to me. I'm just saying, I totally agree. I wish that was a good place to spend our time, but it just isn't going to work. We'll be a force for good. We hope that works, but
It's astonishing that Medicare, what we ended up with Medicare D was 42 different plans.
Right.
And in 42 different plans, they can hide a lot of weird stuff about, you supposedly can go online and say, I'm on drug A, B, and C, and this is the plan for you because it's going to be cheaper if you go with the pharmacy plan 1. But then you get put on a new drug only to find out that your pharmacy plan 1 is no longer your cheapest option and you can't change for a year.
I understand that.
Yeah.
I'm just saying that I think that should be one of your goals, is to figure out a way to regulate pharmaceutical prices. Because that's going to help you as well as us keep costs down.
Then you had a question here?
Yes. There are co-insurers and Advantage plans associated with Medicare. Will we also be one of your payers, or is it strictly Medicare that you're dealing with as one of your sources?
it's really Medicare, regular Medicare fee-for-service, and for the primary payer piece of it. So secondary insurance on Medicare is not part of our program. Will work exactly like it would in a normal system. We can contract with Medicare Advantage carriers if they wanted to take advantage of cost and quality initiatives. We can. We just haven't chosen to contract with them yet.
Only 5% of Vermont Medicare participants are in Medicare Advantage.
Okay.
That it's such a tiny percentage.
Why is that?
I think in some parts of the country, 50% of the Medicare patients are in Medicare Advantage. I think it's,
I meant Vermont.
huh?
I thought you meant Vermont, only 5%.
Vermont is only 5%. Some parts of the country, it's 50%. So why is that? I think it's because the insurance companies that do Medicare Advantage, the insurance company, instead of the federal government, is administering the Medicare. And they market like crazy in those, like Los Angeles. They market like crazy because there's millions of people that they can make lots of money on in Medicare Advantage. And little old Vermont, you know, the marketing expense versus how many people they might sign up.
Plus conservative New England. You got to basically waive getting your fee-for-service Medicare rights, which is a government program with a lot of protections in it, to hopefully get a better deal, but you got to deal with an insurance company.
And you might not be able to afford it either.
Medicare Advantage is typically cheaper, and it
Medicare.
actually is,
Yeah.
than regular Medicare, and it narrows your choices,
Okay.
and a lot of people don't want to give up their options.
Okay, for me, I didn't get that information when I got quotes on it, but, you know, so I don't know. I'm sorry, I didn't mean to interject my question in the middle.
Sorry.
Look in the back. That's you.
It seems that your goals are dependent on patients having primary care doctors. There is an extreme lack of primary care doctors, and especially there are no doctors coming in to the system's primary care. I understand they're about the lowest paid medical doctor there is. How are we going to, or how do you suggest that you overcome that and increase the number of primary care doctors available in Vermont?
So, yeah, no, I believe it. There's, you know, boy, you guys are asking stuff there's no easy answers to, but I think we can make a dent in that in the 5 years. That's one of the measurements, is to increase access to primary care of the all-payer model. But we are really actively taking steps to get more financial resources to make primary care practices have more resources to expand capacity, take on new patients, attract new doctors. We really believe that we could, if we stay the course here, make Vermont the #1 destination to come and practice primary care, because it's adequately supported in a way that there could be a quality of life for the physician in a team-based model with panels that they feel like they can deliver great care to. I think over time we could actually market Vermont for that, because Vermont, I would purport that Vermont would have a brand that primary care doctors would say, really, I can go to Vermont and put up my shingle in one of these beautiful communities and actually have a decent quality of life rather than being on a treadmill in a big shiny box in Raleigh, Durham.
Just for clarity, what do you mean by panel?
Panel is a term typically for an individual physician. How many patients are they their primary care doc? Okay, so a typical the number forever has been around 2,000 people a single primary care doc can do. Because some will be sick and need to be seen today, you know, but if you get much more than that, too many people are calling for same-day appointments and you can't do a good job and focus on them. So that's it.
So I just want to ask if you can break down, so, and I'll give particulars. So I have a Blue Cross Blue Shield plan. I know in Bennington we're not, but theoretically at some point OneCare, right, would.
Yeah.
So, and my plan costs me $9,800 a year. Tell me how much does Blue Cross keep, and how much do they send to OneCare, and how much does OneCare send to my primary? If I need an operation or a specialist, like where is, I don't get where the money's floating around. That's what I want to.
Okay.
What is the mechanics? $9,800 a year. So tell me where does that go?
So the model that we have for Medicare and Medicaid, and that we're going to have next year with Blue Cross. So for this year, your providers are still just sending claims, but it's on our target. So it's we take risk on the claims spend. But where we're going and are there with Medicare and Medicaid is out of the $9,800, if that's the target per person for our Blue Cross contract, we want them, send us the money you think you would spend on fee-for-service for the providers and hospitals in our network. Okay?
For the individual or just?
On the whole population, because your $9,800 premium is meant to be for people who would spend more than $9,800 and less than that, right?
And what is that number? You must know that
So,
number.
so it's about 2/3 of the spend just for the hospitals alone, right? And so we'll get 2/3 to 3/4 of $9,800 to OneCare that we then pay, the fixed payments to the hospitals, we'll pay the capitated rate to the primary care as our model.
And how about if I have to see a specialist, or 5 specialists, like where's?
That specialist would send a claim to Blue Cross and they would pay the claim fee for service, but it goes on our tab.
That's separate.
Against the $9,800 is our target. They send us 2/3 of it that we pay those providers in our network.
So the 25% that they keep, right, does that just go to Blue Cross?
They keep it to pay the fee-for-service claims for the people that aren't in our network or aren't getting payment refund.
So if there's hospitalization, if there's specialists?
Yeah, if you end up in a hospital in Massachusetts or Florida where you're on vacation, right? They're not in the OneCare network. It's not included in the 2/3 that they send me ahead of time. They would pay that fee for service, but it goes against our $9,800 target. So if that's the source of an overrun, we pay for it.
So I guess my question is, when it goes, what you get, how much goes to my primary and how much goes to the other medical costs I might have?
I think it's important to recognize that your $9,800 is the money that's being paid into the kitty to supply hundreds or thousands of people. We can't keep track of we can't follow your $9,800 because some years you might spend $200,000 and some years you might spend $500. So that's what insurance
So if I'm
is.
overspending that, is that coming from OneCare and your risk thing, or is that coming from Blue Cross and their risk thing? You know what I'm saying?
We take over the risk for that.
You take over the risk.
Okay, Blue Cross may be the one distributing the money versus us distributing the money to our
So they're kind of
providers.
keeping their admin, whatever they do for whatever they, marketing, advertising, I don't know, plus pharmaceuticals is coming from Blue Cross Blue Shield. All of my other is part of this other, you're another layer, kind of a direct service.
But if this works right, if we're taking the risk, Blue Cross has $200 million of reserves so that they don't go insolvent, right? If it was a bad year of utilization, they need to have enough money in the bank to pay those claims. That's part of what an insurance company is. Instead of $200 million, if we take all their risk, they might need only $150 million, and they can then put that into premium relief because we're taking the risk. So that's why I'm saying it's sort of a shift within an existing layer that's going to exist no matter what. So just because we're the last player in that layer doesn't mean we're not your best hope.
I think we probably have time for like 1 or 2 more questions, so there's one here and one over here. Is it?
I'd love to get one more.
I know, I'm just trying to, they
I don't know how long we have the room.
have a long drive. Oh, we have, I'm just worried about you because you had a long drive down
It's all
here
good.
again.
It's all good.
Go ahead,
All
sir.
right. Actually, you just answered one of my questions.
Okay.
In about a year, I'm going to be going on Medicare. When I sign up, does that automatically go through the ACO here?
So if you have an established relationship with a primary care physician that's in the OneCare network and you're a Medicare benefit holder, you will attribute to our accountability for your care. Did that answer your question?
The performance of your brand new Medicare policy, you should feel no real difference compared to whether you are or are not attributed. The only difference we hope you're going to experience is that if you are in our program, that if you were ill and became ill and needed those extra services, that you would be getting them in a way that might not be available in just the regular old Medicare way.
If this works really well, you next year will actually want to go to a practice that's in OneCare because you think you're going to get a more proactive plan to help you stay healthy.
Did you have a question? No, I'm not.
I had actually two questions, but I can just express them both clearly, I think. The first is there's a real profound paradox here that you must have thought about. So, and that is there's several big studies that say, and they're quite consistent, that the waste in the U.S. healthcare system is somewhere between 25 and 50%. The Institute of Medicine says it's 30%. Okay, and so you have all this documentation that there's this waste out there. Then if you talk to any physician, they would usually concur with that too. And then we have all this experience with ACOs, very bright people, very dynamic people, and they're trying to figure out how to do that. And you'd have to say that the results of ACOs, the standard term is underwhelming. They haven't been able to get their handles on that 25 to 50% waste. So why do we have these good studies by Wall Street firms, by major think tanks, says there's 25 to 50% waste, and we have the experience of all these ACOs, which sort of just break even kind of thing. Can you explain that paradox?
One thing to let you know, the rate of growth since Medicare did the ACO programs for ACO attributed lives is 1 to 1.5 points less than the Medicare fee for service. Very few of them qualified for shared savings because Medicare makes you save 2% before you get a dime from them. Okay, so I reject any supposition that ACOs have been a failure. Okay, number two.
So you're saying 1% of something is good. I mean, that's what you're saying.
All I'm saying is ACOs have provided higher quality at lower cost growth for 5 years for Medicare. That's all I'm saying. That is the fact. Okay. People want to do studies that show because they didn't get shared savings, save enough to get money back from the federal government, that is quote unquote a failure. OneCare has never gotten a dime from the federal government, and we've been in that top value quadrant every year we've been in the program. The program is not incented to reward value on the upside model because you got to eclipse that hurdle rate before they give you anything. It's very much tilted towards CMS. So that's one thing. The other thing I would say is I agree that there's waste in the system. I'm not sure if I believe 25%, but what this is about is, God dang it, let's capture the first 1 to 1.5% against what we'd otherwise grow at. Let's start with that and try to find those and see if we can be successful for 5 years, which would be unprecedented, again, in the United States. So that's what this is about. It's just at least trying to find that first bit of that waste and see how far we can go. I hope we're so successful in year 3, the Green Mountain Care Board could turn that dial from 3.5 down to 0. I don't know about negative, but, right? I hope we're that successful. That's what we're trying to do.
So to additionally try to answer your question, that the problem is in ferreting out the waste, it's what is it? One person's waste by their assessment is another person's valued service. So the sensitivity of the public to have a perception that somebody like us is telling your doctors what is the waste as opposed to not, or agencies who are already struggling with their budgets. So it's hard to know what it is, and it's only because of the data being in the hands of clinicians to sort of study and find the differences and try to figure out and convince our colleagues that they're different and that maybe they could do something different.
That is the hard part of that. I mean, if somebody comes in the emergency department with a certain set of symptoms and 30% of the time we give them an MRI, but we know from big studies that only 20% of the patients truly need it, identifying what are the criteria for those 10% that don't need it is really, really hard medical stuff. But I would agree that that's waste, but it's really hard to find that. And what do you do with the person who said, I don't care what the evidence shows, I think something's wrong, I want my MRI, right?
So is one thing that you're doing, are you setting protocols for all sorts of things? What would follow?
There are lots of protocols by the American Diabetes Association, American College of Cardiology, you name it. For every disease, asthma, there are national protocols for what doctors should be doing. Some doctors think that that's cookbook medicine, you know, because they have an impression that they know different, and that following those guidelines, which are sometimes very complicated and time consuming. So we get sort of in a rut of this is the way I've been doing it for years, and I'm not up on the new evidence.
But we are trying to measure where there is good evidence-based protocols. How often do we get it right? Right? And really the same person with the same needs and presentation and demographics in Bennington versus Newport, you know, if we know what the right thing to do tomorrow is, that should happen tomorrow. And that should happen 100% of the time if there's a good game plan. So we're trying to facilitate local communities and networks and medical homes to have the plan and get it right more often than they otherwise would.
Can I go back to, I'm sorry.
You're next. Yeah, I'll let that, Terry, go ahead.
I just want to know, how do we find out if a provider is part of an ACO?
On our website, we list the providers, right?
Yes, you do.
Yeah.
We go to your website to see.
So which doctors are participating? Now, we've talked about attribution. And the attribution process is based on medical claims, and it's not a perfect process. So sometimes we might have an example of Mrs. Jones who's been seeing Dr. Ward forever, and for whatever reason, you know, she might go to Florida and be seen 3 times, which is more than she saw me last year. And even though I'm participating in the ACO in Vermont, she might be attributed to a Florida ACO for all I know. So it's not 100%, and it's a little bit confusing, but that's the way it's supposed to work.
Well, if you're talking about, you know, having a better, more inclusive care model, and we want that more inclusive care model, how do we find it or encourage our providers to be part of that?
We want the aspects of our program to be desirable for more and more, especially primary care doctors, to want to be in the program, so that more Vermonters will hopefully be experiencing what we've been talking about today. As far as getting Medicare, Medicaid, and Blue Cross to change the way the attribution process is done, like you being able to say, my doctor is Dr. X, and gee, I somehow the attribution didn't connect me with that person. At some point we need to have a process that, those relationships are.
And a lot of our tools are dependent on the attribution and the claims history to drive some of it. But some of the innovations and protocols, if they get used to doing it right at the same time every time, will have a halo effect over to the rest of the panel. And I think we expect that to happen. I mean, the doctors want to practice in this model, and I think that you'll get good benefit even if you're not part of one of the covered populations we contract with, or even if you don't attribute. So.
This should be a lot simpler than most of the questions you had recently.
No, this is all great.
I'm truly mystified by some of the basic mechanics of this system. A patient comes into a primary care doctor.
Yeah.
Primary care doctor is participating in OneCare.
Yeah.
When you get to the point where you're covering Blue Cross Blue Shield and commercial policies, that person's policy is going to have a deductible. It's probably going to have a copay. And there are probably going to be services and things that are simply not covered by the policy. How does that work in practice?
So right now, ACOs don't, at least the programs we're in, we don't affect the benefit structure at all, including what the patient owes, right? So even though the plan portion of the payment, we work out and handle that on average based on the models for the year, your out-of-pocket experience will look exactly as if it's a fee-for-service system.
So if that was me coming in,
Yeah.
and I hadn't satisfied my deductible yet, and I also had to make a copay, say that.
You'd still make that payment, and the provider would get that.
The provider.
Yeah.
Okay, what about services that aren't covered? The provider's gonna know that?
Just like they would today. It would work just like it is
So
today.
all those administrative functions and costs and tracking of benefits is still gonna be out there?
It will, and somebody's gonna have to do that no matter what.
Well, there are other ways to do it, this is.
As long as we have an insurance-based system, you're right.
Right.
So all that stays in place, and you need to keep track of that before you go to the doctor, because you have to know that you're gonna have
Yeah.
to pay a certain amount.
Yeah, and this is no, we can't. We're not unburdening that on you. We can be a force for good in this one, much more so than the pharmaceutical, to work with the insurer to say, hey, does it make sense that their primary care visit, that primary care ought to go against their deductible? Can we work on maybe exempting that from the deductible model? We can work with them on those models and encourage them, and probably have a lot more success, especially since we have an in-state, nonprofit, Vermont domiciled insurance company that's the largest insurance company. Especially with them, I think we can work with them to at least make some improvements and lower some barriers where probably there shouldn't be.
How are you?
Rachel? Oh, I'm
Just
sorry.
a hard question. One of the things for me that's hard with insurance companies that say they're nonprofit, when I look at pay salaries for CEOs and other, so you guys are nonprofit, can you just give us the range in terms of, like, you might be nonprofit, but, you know, again, our insurance money paying for people's, you know, high salaries and bonuses, and wondering.
Yeah, I'm not going to get into any specifics, but we benchmark salaries based on people who do like roles in like organizations nationally.
Insurance companies kind of, is that what you're?
Yeah, and insurance companies and healthcare is a pretty mobile labor market, and that it's I get recruited recruiting emails every week, but I love Vermont, so I stay in Vermont, and I'd like to be able to. So.
Yes, in the back.
I just wanted to say, I really applaud the idea of the ACO. I think that the goals and the intent of this program sound really attractive to me, but I'm curious about this notion. Are you partnering with the insurance companies? Because all the sites that Lee mentioned, the fact that people have, expenses that really kind of prevent them from taking advantage of healthcare services, it's going to affect your outcomes. I mean, you're not going to have as good outcomes and as good quality of care kind of results if people aren't getting to the doctor because they have all these expenses that they can't afford. So my concern is that if you were partnering with Blue Cross Blue Shield, or if you were, trying to find ways to work with these private insurers that we're all tied into to keep those costs down, then I think the ACOs would have a much better track record. I think you'd be a whole lot more attractive, and I think you'd have better results.
Well, and again, that's the one area that I think, especially with Blue Cross Blue Shield of Vermont being, headquartered in Vermont, that I think we can work together to figure out what are some things we can do, for whatever period we're in an insurance-based system, to make it more affordable, more friendly for people, not duplicate resources. And Blue Cross Blue Shield, I truly believe in my conversations with them, that they do believe that they can start to reduce their infrastructure as we gain more and more of their patients and take that risk, and actually live up to what we're saying is you don't have to hire a disease management vendor anymore, Blue Cross, to try to do this. We're getting it right based on the protocols and the quality measures in the primary care office. So that one I'm a little bit more encouraged we can make some progress
Well, our
on.
hospital is definitely tied into the ACO system, and most of the primary physicians who work in Bennington are also hospital employees now. So we're definitely a part of this program at this time. So, and they have a home, medical home service. I mean, Green Mountain Care came down and did a presentation in the fall, and they talked a lot about the way the hospital is managing patient care.
Yeah.
So it's all moving in that same direction.
Right.
So it sounds.
So I think if there are any other burning questions, we could maybe email them to you or something. I mean,
If you want to collect follow-up questions,
I think that,
That would be fine. We'd be fine trying to provide some
These
written
questions
replies.
are very valuable to us.
okay.
I can't thank you enough for being here and taking time out of
Oh,
your
no,
personal lives
thank
to be
you
here.
very much.
This is fantastic, so thank you. Glad to be here.